Welcome to our Caribbean and African Targeted Health Improvement Program, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CAHN is funded by the National Lottery Community Fund.
A very warm welcome to everybody this morning. Good morning. Good morning to you all, and welcome to another CAHN Health Hour session. These are health hour sessions that we have a week in, week out every Saturday, bringing in our Black consultants and GPs and clinicians to empower us, to educate us, and to give us that space to sort of discuss relevant topics that would give us the ability to understand our health better and improve our overall health outcomes. My name is Dr. Diana Asante, your regular host for this program. I'm a GP, and it's my pleasure once again to welcome you. And we do appreciate the time that people take out every Saturday to join us and to join our other health sessions out of their busy schedules to learn a bit more. I know that we're, as a nation, in a state of mourning as we prepare for the funeral of our late Queen Elizabeth. And our heart goes out to the royal family and to everyone who's been affected in one way or another. Now, these CAHN Health Hour sessions, as we know, is hosted by CAHN and its partners. We, during these sessions, have you on Zoom here with us, but we've also got people watching us on Facebook, engaging on YouTube and all other social media platforms. And we recognize you on those platforms too. Today, we have a very important topic, as usual, probably one that we've talked about in the past, but because of its importance and relevance, we felt the need to talk about again, and it's about beating stroke in Black people, beating stroke in Black people. And we do have a very important personnel today to deliver this session for us. As we know, Black people are at a much higher risk of having stroke or suffering a stroke in their lifetime, and some people even do suffer repeated strokes as well. I have a personal story where I've just lost a cousin just over 2 weeks ago. He died of a stroke. He had his own risk factors. He was overweight. He had blood pressure issues. And that was his second stroke. And unfortunately, he didn't make it. So I know that each and every one of us might know somebody who's had a stroke before, or experience something like that, and this session is meant to just equip us so that we know a bit more. So beating stroke, we want to know a bit more about it. How can we prevent it? How can we minimize the risk? What can we do to sort of help ourselves, and what can the knowledge that we do equip us to do when we have discussions with our clinicians or when we are confronted with situations regarding our health. So today we have a consultant vascular surgeon who is very knowledgeable and very experienced in his field. He works in the stroke prevention service. He also does operations related to the vascular surgery. And he is someone who works in the Northwest region. he says that he doesn't like introducing himself. And I know that he has a lot under his belt. So I've just sort of given you a little summary, and I know he's hopefully going to tell you a little bit more about himself. But we have Dr. Deji Olojugba, Dr. Deji Olojugba, and he is going to be our resource person for today, a consultant vascular surgeon who is well versed in the area of stroke, and he will tell us all that we need to know about it. We will have our usual question and answer session after his delivery, and so do post your messages in the chat box, post your questions there, do interact as we go along, and send in your comments. We really appreciate these. We will be sending out feedback forms as well as we go along, so that we can get your useful feedback to be able to bring you the programs that are meaningful, that are useful to you. So it's my pleasure to introduce Dr. Deji Olojugba, our consultant vascular surgeon. And thank you so much, Doc, for taking out time out of your busy schedule and honoring our invitation on this Health Hour session today. Over to you, Dr. Olojugba, and thank you once again.
Thank you. Can you hear me at all?
We can hear you perfectly.
Oh, right. Okay. And can you see my screen?
So we can see you, not the screen that you...
Not my screen. Okay. I will get back to my screen. I think we set everything up, and then in true technology style, things have to be adjusted a little bit. So just to,
these things happen.
Get back into, we did check everything out.
And that,
I guess you can see my screen now. Okay,
super, we can see it now.
Thank you. And I'll get the slice on beginning. All right. Okay.
Great.
And right. Good morning, everybody. Can you see my screen, and can you hear me?
We can see it and we can hear it. It's
great stuff. Great stuff.
Great.
Thank you and welcome, and thanks, Diana, for that introduction. And also thank you to CAHN for inviting me back. I thought that my last few presentations were disastrous, but then it seems that they were not. But thank you for inviting me back. It's a real privilege, talking to my community and sharing my knowledge, expertise, and skills. I really enjoy it, and I love the feedback, and I love the interaction, and it's really great to know that in this way that I can contribute, and my other colleagues can contribute to the community, the knowledge, and our health in general. So today I'm going to speak about strokes in the Black community and how we can go about reducing those risks. Start about talking about myself, introducing myself. I know I have been, Diana just say a little bit about me, but yes, I'm a vascular surgeon. I'm a vascular surgeon working in the northwest of England. I work in Chester to be specific. I qualified in Nigeria many years ago. And my day-to-day work is in vascular surgery. I do operations that prevent strokes in a certain group of patients. There's vascular surgery extends to the legs and treating diabetic complications in legs as well. I also have a newfound interest in digital health, which I think is very transformative, and it has the power of bringing health closer to us all, and hopefully helping to improve the quality of all our lives. My main disclaimer here is that I'm not a cardiologist or a stroke surgeon. I'm sorry, a stroke physician rather. I'm not a stroke physician, and they may take a different take, and obviously that's what they do from day to day. But I hope you do get something from what I have to tell and discuss with you today. Okay, what am I going to talk about today? I'm going to cover and give a definition of stroke, and discuss the different types of strokes, the risk factors, and drill down to how strokes affect the Black community, and hopefully have a insight into how we can actually reduce strokes specifically in our community. So the medical term for a stroke is a cerebral vascular event, and you'll probably hear this word CVA. This stands for cerebral vascular events. And if you Google the origin of the word stroke, it actually comes from the initial description of what happened to a patient that had developed a stroke. Hippocrates will say it was an apoplexy, which means sudden collapse, and as if stricken by something. And I guess that's how people used to see it in those days. Obviously, our knowledge of strokes and our understandings has improved from the days of Hippocrates. But in effect, it is a sudden loss of neurological function as a result of interruption to the blood supply to the part of the brain. I know that's a bit of a lot to say, but essentially the important thing to note is that it is sudden. And what happens as a result of that is that there's a starvation of part of the brain of oxygen. And dependent on that starvation, the brain manifests some clinical events. Now, there are two main types of strokes. There are other types of strokes, but there are two main types of strokes that I will share with you today. The first and the commonest is the ischemic stroke. Ischemia meaning lack of blood supply in some respect, and it is up to 70 to 80% of all patients presenting with stroke will have an ischemic stroke. The other cause is a hemorrhagic stroke. Hemorrhagic means bleeding, and that accounts for 20 to 25% of all cases of strokes. And the hemorrhage meaning bleeding from a blood vessel within the brain. Now, we'll talk a little bit more about that later on within the talk, but then at least from this slide, it would take away the message that you've got two main types of stroke, either ischemic or hemorrhagic. Now, ischemic strokes are caused by a clot lodging in the vessel that is that is supplying that part of the brain. Now, sorry, coming back to hemorrhagic strokes very briefly. Why would a vessel suddenly bleed? It will bleed because it's been diseased, and that diseased vessel often is in the brain, and it may be a large vessel or maybe a small vessel. Now, in our community, the evidence suggests that there's a high incidence of hemorrhagic strokes in our community compared to other communities, certainly compared to the white communities. And unfortunately, the hemorrhagic stroke can have a worse outcome compared to an ischemic stroke. Thankfully, it is not as common as an ischemic stroke. Remember me talking about clots lodging in the vessels in an ischemic stroke. And the question really is, where do these clots come from? They can come from a variety of sources. They can come from the heart. Now, you know that the heart pumps the blood, and the blood goes everywhere, including the brain. And if the clot starts from the heart, it may travel to the brain and cause an ischemic stroke. And there are certain circumstances that those may arise. And you would have heard of atrial fibrillation. And atrial fibrillation is a form of an irregular heart rhythm. It's perhaps the most commonest cause of an irregular heart rhythm. Other situations may occur in the heart when you have when you're prone to developing clots within the heart, and patients, for example, who've got a diseased or replaced heart valve may be prone to developing clots in the heart, which could travel to the brain. Bear in mind, they could travel to other parts of the body as well. The other source of these clots could be vessels, could be the vessels leading to the brain. And this is where I come in as a vascular surgeon. Now, note two words. If the vessel that is involved, it's outside the brain, it is termed an extracranial vessel. Now, that's an extracranial vessel there, and they're named vessels. One is called the carotid artery, the other is called the vertebral artery. They all lead to the brain and are the main extracranial vessels in the brain. But also, The clots can occur in vessels within the brain, i.e. intracranial vessels. And these are vessels often diseased within the brain. And these vessels can form clots in them because they are diseased. Some situations, clots can form in a vessel not necessarily directly related to the brain, but because the blood itself has a higher risk of clotting. And very, very pertinent to our community is the incidence of sickle cell disease. Sickle cell disease patients, if not managed well, are prone to strokes, and these strokes occur because the blood clots abnormally or has an increased tendency of clotting. Other situations occur, certain cancers and certain blood cancers can occur, or certain blood disorders do occur and can cause or cause an increased risk of clotting that can cause strokes. And they may cause clotting in other vessels as well. Sure, we're all kind of familiar with the symptoms of a stroke, but then I'll go over some of them again. We know that strokes can be silent, and this is particularly important that some patients may have repeated strokes, not aware of it, and they may manifest in situations such as dementia. However, symptomatic strokes, strokes that have symptoms, can be transient, can be on one side of the body. They may affect your eye, loss of vision, one way, maybe partial, maybe temporary, maybe permanent. We talk about difficulty in speaking, which has various grades, ranging from difficulty in actually speaking to difficulty in actually understanding and to difficulty in actually expressing. The face may droop, and that droop is usually asymmetrical, meaning that it is one side compared to the other. And the more obvious strokes can occur in the arms or the legs, where they feel weak, or you're able to move objects or lift objects or do what you normally would do, what to do with your arms or your legs. More massive strokes can be associated with loss of consciousness, collapse, and strokes in the hind part of the brain can cause problems with balance and coordination. We also describe stroke syndromes, and that's more related to the duration of the stroke, and to a certain extent to the severity of the stroke. So you would have heard of a TIA, and a TIA there is a transient ischemic attack, also called a mini stroke. And its definition really is more time bound in that it is transient and lasts less than 24 hours. It is important because it can be easily missed or mistaken for something else. It's also important because it can be a precursor of a more major stroke in the coming months. So it's important that if we have signs or symptoms of a TIA, that they're dealt with immediately. In fact, hospitals all over the country have specialist clinics called TIA clinics, which are manned by stroke physicians and stroke nurses. There's a minor stroke, which is a stroke that lasts more than 24 hours, but doesn't cause any significant residual disability. So the patient, for example, may have a residual weakness, but doesn't not necessarily affect their quality of life or the things they need to do. And correspondingly, in the brain, the area of damage is quite limited. Then you obviously have the more major strokes, devastation, where you have real ongoing disability. Also, the strokes in evolution, it's actually a different category, but that means a stroke that's happening, maybe recurring and slowly and rapidly escalating over a period of time. And as I said, your stroke can affect your face, your arms, your vision, your speech, your cognition, and your level of consciousness. And again, we'll talk a bit about that a little later on. Now, I'll just talk a bit more in detail about how this actually affects us in our community and how relevant that is. Studies vary, but I think there is a consensus that strokes are commoner in blacks than in white. And some people will say up to 2 to 2.54 times more likely strokes in our population than Caucasians. Worryingly, they tend to occur at a younger age, almost 10 years younger than the average population of the Caucasians. There's evidence in some studies that there's a decline in the white population, but no such decline in the incidence in the black population. So one has to wonder, what are they doing right, and what are we not doing? There's also evidence that it's not just about the socioeconomic factors, not just about deprivation. Quite clearly, deprivation and socioeconomic factors plays a role, but it's not the whole answer. When you drill down to it, and when we come to talk about the risk factors, I think there is a recognition that some risk factors are less common in Black people, and some risk factors have more of an effect in Black people than in whites and or even other races. Not just about Black people versus white people. Even amongst us Black people, there are differences in the perception of strokes. For example, Black Africans, we tend to have a small vessel disease, intracranial vessel disease. The problem tends to come less often from the heart, and there's a lower incidence of atrial fibrillation. Now, this is interesting because it's not clear whether it's because we don't measure it or find it that often, but overall, a lot of the studies will suggest there's a lower incidence of atrial fibrillation compared to, for example, in the Afro-Caribbean population. And again, some studies will suggest that things like cholesterol and heart disease is less in the Afro-Caribbeans than the Black Africans. And when we often look to the United States, where they have a large Black Afro-Caribbean population for data, for results, and on which we base some trials and our evidence. However, even there's a disparity, suggesting that in the US, patients who have strokes tend to have them more from larger vessels compared to Afro-Caribbean and Black Africans in the UK. Now, this slide I found quite interesting, and I'll take you through it. It's a study done in London and taken about 3 major boroughs and they took a population of Black and white, equal numbers of 1,200. And this is just to show the kind of differences in how the strokes manifest in these different populations. So if you look at what we will term as, let's say, intracranial disease, that means small vessels in the brain, you find out that there's a higher tendency in the Black population compared to the white population. Now, you've heard me speak about extracranial problems, extracranial being those vessels that lead to the brain but are outside the skull, okay? And this is important because in the Black population, there's a lower incidence of extracranial causes of strokes compared to the white population. And my job as a vascular surgeon is often dealing with this extracranial. And you can see that most of my patients, in fact, nearly all my patients, are going to be white patients. The more difficult ones to treat or deal with are the small vessel diseases within the brain. And you can see when you look at the Black stroke patients in this population, there's almost a 2-fold to 3-fold increase in incidence of small vessel disease in the brain in Black people compared to white people. Now, cardioembolic refers to the situation when the clot comes from the heart, all right? And that will occur in patients who have atrial fibrillation, for example, okay? So again, when you compare our Black Black people with white people, you find out that white people tend to have a higher incidence of strokes coming from the heart or related to the heart than Black people. Okay. One final important message here is that almost a quarter of strokes across all the populations have no known cause. Now, the risk factors are well known to us all, okay? So age, smoking, diabetes, obesity, hypertension, atrial fibrillation, high cholesterol, they're all there. What is coming and what I'm trying to bring out from this is that the impact of these risk factors is not uniform across all the races. Hypertension is a particular problem amongst us in our community. So if we're going to tackle it, we do need to emphasize on this. And specific to us, when we're talking about risk factors, we need to include ethnicity. We need to include the fact that as Black people, we are at a higher risk. Not just the socioeconomic and not just the sickle cell disease, which affects a proportion of our population and is rising amongst mixed race children, but also the possibility that there may be some genetic factors that are still yet to be detected that are giving rise to this disparity. So how do we reduce the risk in our community? I'll say it's not just about inequalities, though I would admit that inequalities, do exist. But just like forums like this are in place, we need to have a holistic approach to reducing those risks in our community. It has to be for everyone working together. So we must raise awareness. And in raising awareness, we must educate. We must explain things to people, to members of our community, so that they can be engaged and empowered. And we should also signpost people to the various areas of information, resources, and the people that are involved in stroke management, stroke prevention. And the importance of the community approach is that there will be a cultural relevance and therefore a higher chance of making a difference. So if I unpack this a little bit, so how do we raise awareness? Well, first of all, we do need to, I think we all understand, we do need to make everyone aware of this prevalence of stroke in Afro-Caribbean populations and the fact that, we are at a risk population. Emphasizing the impact of it on the community, leading to disability and death, its connection with dementia, and the disproportionate number of patients having dementia in our communities compared to other populations, compared to the white population. And then we need to drill down to these risk factors and being aware of what constitutes a general risk factor, what constitutes a specific risk factor, and individual risk factors that boil down to everyone. So with the education, we start talking about, as I defined what a stroke is, so we have a better understanding, a clearer understanding of what actually is going on when the patient has a stroke. As I've defined the various types of strokes, I think that in itself allows us to have a better understanding. You're all aware about the campaign we see on the TV about awareness and recognition of a stroke. They talk about it affecting the face if your face droops, arm weakness, speech issues, and the need to act because it is a time event. I think these are important educational and awareness campaigns, which we need to drill down to our various communities. In some respect, I will go beyond the fast, because recognizing that there are more subtle signs that as Black people, we may tend to ignore. and we shouldn't ignore them. The odd tingling that you get, the facial numbness that you get, the blurred vision or transient visual loss that comes transiently and goes away. Okay, I'm not saying that they're all stroke related. I'm saying that we need to take them seriously, because those may sometimes be the telltale signs that we need to know and react upon so as to avoid and reduce the chances of developing a stroke. I think it's important that there's an opportunity to provide explanation. To provide an explanation for questions asked, and not just throw words or throw pills at our patients. Okay, so there will be questions like I've been asked today to talk a little bit about atrial fibrillation. We've all been told to reduce the salt in our diet, so why is this important? How does aspirin work? Why should I be taking all these pills, doctor? Take, for example, atrial fibrillation. Now, this is important because you'll see me throwing words around like cardioembolic, and I try to explain that cardioembolic means that the clot that's lodged in the vessel in the brain has come from the heart. And it often comes from the heart because the heart is not well. It's forming clots. And it's forming clots often because it's fibrillating. And fibrillation is because a certain part of the heart is not contracting as regularly as it should do. It's basically shaking, so it's ineffective. And the explanation for atrial fibrillation is complex, but it's essentially an electrical malformation, electrical malfunction in a part of the heart that spreads to the rest of the heart. And it causes erratic pumping of blood and erratic muscle movements in the heart, such that the blood either pools in certain parts of the heart, forming little clots, and it's these little clots that end up going to the brain or other organs. As I said, there is a kind of suggestion that there's a lower incidence of atrial fibrillation in Afro-Caribbeans. But there are also studies to suggest that this incidence is on the rise. And there are further studies to suggest that as a community, atrial fibrillation is being poorly treated, and meaning that we're not getting, that enough of us are not getting the anticoagulants as the blood thinning agents that we require to stop the side effects or the complications of atrial fibrillation. What about salt? We all know that we're sensitive to salt as a race, but there's evidence, clear evidence, that excess consumption of salt increases stroke risk beyond that what we see with blood pressures. A low salt diet can reduce blood pressure. And to put this into some form of context, whilst not absolute, right? If you can reduce your salt intake by 6 grams from less than 6 grams a day to less than 6 grams a day, you can effect a 6 to 7 millimeters drop in your blood pressure, which may equate to an overall population reduction in stroke risk of about 24%. Now, these are not absolute numbers. And often some studies will say that the reduction in salt doesn't cause such a drastic reduction in blood pressure, which is actually true. But those little things help. And that is a significant way of us reducing strokes specific to our community, given the fact that we are sensitive to salt. And you will see salt in all the diets and all the things that we eat and all the spices that we take. What about the tablets? It's still trying to explain away certain things. So An aspirin is a type of antiplatelet, and platelets are cells within our bloodstream that are responsible for making clots form. So the rationale and the logic is that if you have a tablet that can stop the blood from clotting or sticking together, that should be a good thing, and that it is a good thing. They stop the blood from sticking together, but they're not technically blood thinners. Blood thinners are anticoagulants. However, various studies have shown that taking aspirin in at-risk groups can reduce strokes by 25%. Now, we all know that aspirin is available over the counter, perhaps not at the dose that you should be taking them. And the logical question is, why can't I just take aspirin and buy it over the counter? And the answer to that is that unless you are an at-risk individual, you've either had an event, or you're diabetic, or you've had a heart problem, or a transient ischemic attack, the evidence does not suggest, does not support giving otherwise normal people aspirin. So there's something called primary prevention and secondary prevention. So aspirin and its other drugs are effective in patients at risk of secondary prevention. So don't go on over and just take aspirin because it's available. Actually, can have some serious side effects. And the other aspect, I think, is about how we signpost. And I think there's an army of individuals out there, ranging from the dietitians to community nurses, diabetic nurses, cardiologists, cardiac nurses, practice nurses, etc., that give us a wealth of information about how we can reduce our stroke risk. And there's lots of online resources. So I put online there, and there are many, many more. The NHS website. I found that the stroke.org.uk is a very useful resource. And it does drill down sometimes to address the issues of Black people and their disparity and increased risk of stroke. With all this in mind, we get to empower each other. We get to recognize the subtle signs and access the health services at an appropriate time, not when it's too late. We get to understand that palpitations need to be investigated. Those tinglings on the side of the face need to get investigated, often by a blood pressure machine, especially for us over 50. You can self-assess and see whether your heart rate is regular or not, and discuss this with your GP. In effect, we'll be able to make decisions and be able to address inequalities and discuss our options with our health professionals in a clear manner. Now, the last part of this is how we engage. Now, I'm not sure, but I have a feeling that as Black people, we tend not to engage that well if we can with our health professionals. And there's a whole load of information that is still required. A lot of research and data is required. So often, it is clear from what I've said before that we can't be swept with the same brush as other ethnic groups, because the risk factor profile is entirely different. And as a community, we need to be more innovative as to how we culturally tailor our interventions. And that's a job for not just clinicians, but every single one of us. So the last bit is just talking a bit about how we reduce stroke specifically. And I know my time is going, but again, it's clear to us, lifestyle management. We can't do much about our age, but we can perhaps control how we age. Exercising, not smoking, managing our weights. We talked about diet, and not just salt, but also sugar control. And I pitch here about drinking, okay? 6 to 8 cups of water a day. Sip your way through the day. It makes us and keeps us healthy and hydrated. Control specific conditions, diabetes, hypertension, weight loss, obesity, and heart problems, are all conditions that need specific control and engagement with health professionals to help us to control that. Spoke a little bit about drugs, and there's quite a lot of tablets that are out there, some specific and some general. Aspirin, for example, is an antiplatelet, as I said, and consists of one of the general medications that are available to reduce the chances of stroke. And so is statins, which works differently, controls the cholesterol, and also there's also evidence that it stops the areas of thickening in our arteries getting worse. If you're diagnosed to have atrial fibrillation, then you may be placed on an anticoagulant. This ranges from things like warfarin, which needs regular blood tests, to apixaban and the likes of a group of tablets called the DOACs. And of course, we all know about blood pressure control and the importance. This is where I come into it. And as I said, I don't see many Black patients requiring this surgery. Maybe we should. But this is what we call the extracranial cause of stroke. And this is because an area here has shed off a bit of a clot in a diseased vessel, and that has traveled to the brain. And my job is to clear this out, make it smooth, and reduce the chances of any clots forming here going into the brain. And that is effective in reducing strokes. But as hopefully I have told you and discussed with you, that the causes of stroke are multifactorial. And especially in our community, there are other causes that we do need to address and are within our individual and collective control. This is another slide just talking a bit about surgery and how that surgery called a carotid endarterectomy can help reduce strokes in selected patients. This is almost my last slide. And again, just to emphasize the point, how extracranial disease causing strokes is less common in Black people than in white people. And intracranial disease is more common in Black people. And therefore, when we're looking at reducing the risk factors, we should be looking at addressing specific things like diabetes and hypertension. And that is something that we need to do on a daily basis in our communities. Thank you for your time. So in conclusion, reducing stroke is a collective effort. Yes, we do need to address our inequalities, but several approaches are required. With these several approaches, we can have a collective and empowered community addressing the differences in the ethnic groups. More studies are required, and I'll encourage us all, if we have the opportunity, to take part in studies that will give us more data and equip us with the knowledge required to reduce strokes in our community. Thank you for your time and thank you for your patience.
Thank you. Thank you so much, Dr. Deji Olojugba, that you've really, in just a very short space of time, extensively covered stroke and broken it down so that we can understand and appreciate the importance of stroke and what leads to it and how best we can minimize those risks. So I just want to say thank you so much on behalf of everybody. This has been really useful, very insightful, and it really gives us a lot to reflect on. There are lots of comments in the box saying that was very insightful, incredible presentation, very beneficial. So I know at the beginning you said, oh, I hope this is useful. This has been extremely useful. So really appreciate it. And it's just interesting, isn't it? Week in, week out, all these topics that we talk about, hypertension, diabetes, obesity, all sorts. It just goes to show how every single thing is important, because in your illustration, you've told us about how the risk factors about controlling our blood pressure or our weight or, our salt intake, our diet, etc., all add up. And for me, that's a very powerful message, that we realize that every little helps, and everything we can do to minimize those risk factors are really, really important. So thanks once again for bringing home the message. There are over 100 people on the call. There are people on Facebook, people on Zoom, and people on other social media platforms engaging. So a really useful topic. And we certainly have some questions for you as well. I'm sure you know that. Just for those who have joined us sort of along the line, we've been talking about strokes. We've had our consultant vascular surgeon, Dr. Deji Olojugba. He's told us about strokes, about either poor blood supply to the brain, or a bleed in the brain, or clots, or to blocking off. He's told us that there are different kinds of strokes. We know he's told us that in Black people, we do have an increased risk. I've learned something quite interesting as well about among the Blacks, even within the Blacks, that sort of different, responses in different groups. So how the Black Africans and the Black Caribbeans would have different presentations. So that's really useful. And week in, week out, we learn new things. I just want to say that these Health Hour sessions are brought to you by CAHN in conjunction with our partners, Black Health Initiative, Croydon BME Forum, Enfield Caribbean Association, Rafa International Development Agency, and the Royal House Redeemed Christian Church of God in Sheffield. Right, Doc. So the questions are flowing, and as you can probably see in the chat box. So you mentioned about salt, about sort of our salt intake. And Fiona would like to know, she says, can you elaborate on salt sensitivity? So why are we so sensitive to salt? Is that something common across Black people, regardless of where they live? And are there any salts that are better than others? So that's the first question that I'm going to throw to you, because we see this topic of salt, not just with increased stroke risk because of obviously the link with hypertension and others, but we see it with all sorts, with our blood pressure control as well. And so I'll throw that to you. Tell us a bit more about salt.
Yeah, and I think the issue about salt is a very pertinent one. We are sensitive to salt, and I think the sensitivity is drilled down to the level of the kidneys. And I think our ability to excrete it, to metabolize it, to break it down is different from the white population. And that's also reflected when we're trying to control our blood pressure. You will find that whereas a white person may just need one tablet to control their blood pressure, amongst Black people, we need multiple tablets to control the blood pressure. So somewhere along there is a difference. And yes, I think it covers all, whether you're a Black African, Black Caribbean, US Black, it is across us all. As to whether one salt is better than the other, I'm not clear about that, and I don't know for certain. There perhaps is some evidence of certain formulations of salt that may be easier. I just tend to take the easy route to just reduce our salt. And it's easier said than done, I think, because salt is so important in preserving our foods. Salt is so important for making our foods edible. But there's a lot of salt excess out there that can be reduced.
Thank you for that. And I hope that answers your question, Fiona. And I think another thing with sort of the kind of foods that we eat is there's a lot of hidden salt, isn't it? We historically, we've preserved food, back in Africa and the Caribbean and, back home. A lot of food is preserved with salt. So you have, salt in the fish, you have salt in meat and all sorts. And we like our food tasty and spicy. And, so we kind of rely on it a lot, to the point where it's become so much a part of us that when we eat food that's not sort of got salt in it, you almost think it's bland, and we have to retrain ourselves, I think, to appreciate that all of these add up. I think I think there's a lot of work out there about alternative salts. I see the chat there. Absolutely, there's a lot of work about alternative salts.
I'm not sure which ones work, but I think the headline thing is that if you are hypertensive and you found a sort of alternative that helps you to lower your blood pressure, by all means, use it. Yeah.
Yeah, thank you for that. And there are other ways as well of making our food tasty and healthy, lots of herbs and natural ingredients rather than salts and spices. But thanks for that, Fiona, really interesting point. Can you say why we're not being treated appropriately with anticoagulants? Fiona asks, who says, is there some learning for professionals? So a question again along those lines.
I think so, and when I found this out, I was quite shocked myself. I think that it perhaps goes to the throwback of an understanding of a kind of feeling that Black people don't get atrial fibrillation as much as white people, and so therefore it's under-recognized. It probably is underreported, but it is not clear why, in a community of patients presenting with either strokes, that they don't leave, strokes secondary to atrial fibrillation, that they don't leave the hospital with anticoagulants. It's not clear at all. And I guess one of the rules of this sessions, or these kind of sessions, is for us to be able to challenge that, to say, well, why aren't you doing? So in the diagnosis of atrial fibrillation, for example, I'll just go a little bit now, there are different types of atrial fibrillation. There's the one that occurs and goes away, you never see it again. And then there's the one that occurs from time to time. And the only way of finding that out is to do what we call an extended 24-hour tape. So you do it over a longer period of time. And it may well be that Black people aren't just being given this to assess their atrial fibrillation. So, you take somebody's pulse today, they don't have atrial fibrillation, but if you had waited for another 3 days, they may then develop atrial fibrillation. And that may be one reason why it's undertreated. But nonetheless, we as a people, as an ethnic group, should be able to ask and challenge and ask to be excluded to make sure we don't have atrial fibrillation, so that we're just not undertreated. We're no longer being undertreated.
Thank you. And on that thread, I'd also like to add that on the same topic of atrial fibrillation, which is irregular heart rhythm, as some people call it, I agree. I think we probably underreport, and if we don't talk about these things or present, then it's hard for it to be picked up. As Dr. Deji said, sometimes you have the irregular heart rhythm come and go. So if you have had an episode where you were having palpitations, or you felt funny, or your heart was beating in an irregular way, and you didn't talk about it or go forward to speak to your GP or your doctor, and it never got picked up, or at the time you saw your GP, you were absolutely fine, but the history will prompt them to think this could be something that comes and goes, then it never gets picked up. And then the next thing you realize, next time you're presenting with a stroke. So I just want to emphasize that it's really important that we take these signs seriously. And Dr. Olojugba, you said that really nicely in one of your slides, that let's not ignore the subtle signs, that little tingling that you're getting, that palpitations, which is unusual, which you just convince yourself that, oh, it's fine. Let's not ignore those subtle signs, because, we should take them seriously. It might just be your only opportunity for someone to pick up that you have an irregular heart rhythm. And I think these days, some of the watches as well can tell you if your heart's beating irregularly. I've had a few patients who've come to surgery purely on the premise of my iWatch was recording 140 and it was irregular. And when I checked that person, then their pulse was completely regular. They were absolutely fine, but based on the history, we were able to do some further monitoring, and it turned out that yes, they actually did have atrial fibrillation or an irregular heart rhythm. So let's take all these things seriously. Thank you. Thanks for that. Right, so we'll move on swiftly. Comments about thanking you, comments about appreciating you. Dr. Deji, comments about how useful it's been. So there's another question which has been passed on by one of our digital assistants. He says, thank you so much for letting us know about aspirin. Is it dangerous, someone says, and if so, why is it sold over the counter? So We just want to know, is it dangerous? Loretta has also said some people substitute monosodium glutamate in Maggi for salt. Does that make a difference? So just on the topic of salt, Mia says, I heard pink Himalayan salt is healthier or better quality. So comments in relation to salt and other alternatives or options that sort of people might want to consider. But I guess that the take-home message is reduce your salt generally. But just on that topic of aspirin, is it dangerous? Should it be over the counter? Is it safe to be sold over the counter?
So as you perhaps know that, so aspirin over the counter is about 300 milligrams, and you're asked to take 600, and it's sold over the counter as a painkiller. Generally, because it has two ways of acting. It works as a group of painkillers called the non-steroidal painkillers, which relieve pain. But the dose that is required for what we call secondary prevention or for strokes and other cardiovascular problems is about a quarter of that. 75 milligrams is what is required. So if you're taking it over the counter doses, some people just split it in half. However, we would say, definitely have it under prescription, because you may be taking it unnecessarily. And in terms of danger, it can cause what we call gastrointestinal side effects. It can cause ulcers, it can exacerbate your gastroesophageal reflux, and it can cause bleeding in the gastrointestinal tract for some patients. So why take it unnecessarily if you don't have to? If you do have risk factors, any of those risk factors we discussed, I think the best thing is to go to the GP and determine whether you benefit from aspirin. And indeed, there are alternatives to aspirin, which may not give you that same side effects as aspirin. But to answer the question, over-the-counter aspirin should only be taken, should not be taken in lieu of the prescription from your GP.
Okay, thank you so much. And just to add on to that as well, I hammer the point about the fact that do speak to your GP, or at least let them know what you're doing. So I mean, just purely from a cost perspective, I'm probably being a bit protective of the NHS here. I know that there's some patients who like to buy their aspirin because it's cheap as chips over the counter, but Dr. Deji has made a very important point. You need to speak to your GP. We need to know what you're taking, because it is an anti-inflammatory. It can cause people to bleed. It can affect the lining of the stomach. It can take a hit on your kidneys, and it can interact with other medications that you are taking as well. So a lot of people will tell their doctor, oh, I'm taking aspirin. Is it okay? Is it fine to carry on? And if your doctor knows, that's for people who live, where the healthcare is provided, like the UK. I do appreciate that probably in Africa it may not be the case, but at least so that they know and they can give you advice as to, yes, it's fine to carry on, or no, you shouldn't be taking this. And also so that we are aware that you are taking aspirin, because there are patients who, as you said, Dr. Deji, they're taking it. We don't know they're taking it, and we're assuming they're not on these medications, and then they might turn up with a gastric bleed or tummy bleed, for instance. So do keep your doctors in touch, or communicate. Let them know what you're taking, and if they're happy for you to buy it because it would save the NHS some money, then fair enough. But if you need it on prescription, that's absolutely fine as well. But let us just be aware of what we're taking and let our doctors know as well. Faye, thank you for your comment. I think along the lines of Saul, Faye saying, thank you so much for your presentation, Dr. Deji, and the way in which you explained in layman's terms. It's very hard to convince the Black community to reduce salt, she says. When I visited the USA, they do have spices which does not include salt. However, going to the shops in the UK asking about spices without salt, they just say, oh no, they're not available here. So surely it's down to the shops to request these products. So quite a useful comment. Also, BA saying, great session, Dr. Olojugba, about the differences in the Black and Caucasian trends. This is quite intriguing. And then Maya says, okay, so I think we've talked about that already. And then Pastor Chini is saying, even some of us do not adhere to the investigation advice. they may not apply the 24-hour tape accordingly. Okay, so I think talking about the AF, the irregular heart rhythm, the atrial fibrillation, Pastor Chini is saying that some of us don't adhere to the advice and may not apply the tape. Can you elaborate a bit on that, please?
My screen has gone very funny. I think it's my computer.
It? Oh, yeah, bless you.
I'm not sure why it has, but I'm still with you. I'm not sure why.
Yeah, we can see you. We okay. Haven't noticed anything change.
Okay, I'll just yeah. So the question was about people who don't apply the 24-hour tape because of convenience, because it's awkward, because it, I've had a 24-hour tape before, and I know that it can be cumbersome, and one can only just ask people to try to adhere for the and bear with inconvenience during while it's being done, because it is very important that it takes the time. And some people have it for more than 24 hours. There's an extended one for 7 days.
7 days
in some people, and this is the thing that as I said, there are studies that suggest that the incidence of what we call cardioembolic stroke is reducing in the white population, and that risk factor is specific to them, which, I think as a community, they have embraced, and they have seen a reduction in those numbers. We need to embrace this to see the same reduction in numbers. And, and I know you talked about salt there, and I think that, again, we have campaigns that we see on TV about sugars and things, campaigning to our children, etc. That's of the recognition of the ill effects of these kind of high sugars in our children. We need to have that same kind of campaign as a community, and this kind of and it's not necessarily down to clinicians, but there's an army of people, whether or not they're clinically inclined, that can start campaigns to reduce the salt in everyday food, the foods we like, and it must be within us, because it's only us that knows what jerk chicken is, for example, or what jollof rice is, for example, and what we put into it. So that is where it's going to start from, and that's where the difference is going to be. And if I may say one thing, because I did say at the very top of my presentation about my interest in digital health, and I forgot to mention things like, and you did mention it, about the various gadgets that can help us, really help us, in monitoring our blood pressure, in monitoring our pulse rate, keeping an eye on things. We need to embrace these things, and it has no necessity. The good thing about it is that it's equally available to all ages, all age groups, and we should use this to empower ourselves.
Yes, I agree. Thank you so much. And Faye asks, how reliable are home testing kits for cholesterol? So that's one question. And then the next question from Jaya or Jayi is, could you please explain the information on your penultimate slide, and also show the stroke pyramid slide? So that's something which, if you can address those two for us. So the cholesterol home testing kits, and then your penultimate slide and the pyramid, please.
Right. I don't have much information about home testing kits for cholesterol. One will have to look at the laboratory and have to look at where they validated it. So there will always be an information as to how they validated their data and which laboratories they're taking it to. So I suggest kind of reading the fine print, but I'm not aware of any cholesterol, the efficacy of any cholesterol home kits, but they are springing up everywhere. You want me to share my screen again, you said?
Yes, please. Are you able? So I know you said you had a bit of a glitch. Is your screen up and running?
Yes, I will.
Yeah, so
my screen. Yes.
So Jay, she's asking about, she's asking about your penultimate slide and also the stroke pyramid slide, please.
Okay. I think that's my penultimate slide there.
That's your penultimate one. Mhm.
Yeah. So an explanation about it really is, what strikes me is that as a vascular surgeon, one of the works we do is to prevent strokes. And whilst I live perhaps in the Northwest, an area which is predominantly white, I've been a vascular surgeon for many years, and I can count on my fingers how many Black patients I've actually done these surgeries on, how many Black patients I've actually dealt with who've had an extracranial cause for their strokes. Is it that they don't exist, or we're talking about a completely different pattern of disease? And hence this slide here, just to emphasize, that when they took this comes from this is an extract from the first slide with all the data, showing that when they took 1,200 Black and white patients, that only 5.4% of them had an extracranial cause compared to 12.2%. In my terms, that means I can only make a difference surgically on a very small proportion of white or Black patients compared to white patients. Okay. And obviously this 5.4% that you see here is the same for whether you're Black Caribbean or Black African. Okay. I hope that explains that slide. Now, the pyramid is just, maybe I didn't explain this as well as I perhaps wanted to. And the reason why I think there's a pyramid is that, being a pyramid, the bottom bit is open to everyone. There's a lot of generic things that we can do there in terms of our lifestyle management. Now, so that includes those that don't have any comorbidities, that don't have any other ill health problems, don't have diabetes, don't have hypertension, and are overweight. We still need to engage the lifestyle management. And then the next one really is about those who do have comorbidities, who do have diabetes, and how they engage in controlling and taking ownership of those conditions, be it diabetes, be it hypertension. And there is an overlap, of course. So hypertensive, you still need to exercise, you still need to watch your weight, you still need to watch your salt intake. And then there's the drug therapy, which again, I glossed over because of time and things, but then there are a range of drugs, both specific and general, that when taken together will help reduce the risks of that of strokes. And we've spoken at length about aspirin and its other kind of drugs. We've also spoken about anticoagulants, and there are other drugs though that are tailored to reduce stroke and prevent strokes. And at the top of it, and quite rightly so, as a small pyramid, is the role of surgery. Very small, but there in a selected population.
Thank you. Thank you so much for going over that for us. We appreciate it. I'm just bunching up two themes for you, please, if that's okay. So one of our members of the audience would like to know about, cholesterol ranges, the numbers and sort of what they should be in Black people. I know that's a slightly tricky question for you, but I mean, if you can tell us, or if you can give us a resource to look at, that would be useful.
I couldn't tell you from the top of my head, and I know that cholesterol I find it a complex matter because there are different kinds of cholesterol.
Different kinds, exactly, yes.
Cholesterols, and I think that's something I perhaps need to send in a different chat. Yeah. So
but
you see, like as you know, Diana, when you go to your GP, I would refrain. I mean, the person who said about home testing for cholesterol, when you go to your GP and you have your cholesterol test, they are put into charts, and they can easily quite quickly tell you what your risk, where you lie in the risk range. And I think that one-to-one talk is very, very, very important. So I'd rather go to the GP and let them talk you through your options and what your cholesterols are, the levels are, than try and do it all by yourself at home.
Thank you. And also to add to that, I know that people do struggle to get appointments, and we try and sort of empower ourselves, but I completely agree. When you're certain things, if you're testing at home yourself, you might not be able to interpret it in context. Some of these kits need to be calibrated, you know, it depends on what reference ranges they're using. So just the number, just telling you your cholesterol needs to be less than 5 might not really mean anything to you, because there's a breakdown. We've got the good cholesterol, we've got bad cholesterol, you know, we've got HDL, LDL, and all those things. So I completely agree that have a conversation with your clinician. And also, we don't just take your cholesterol level in isolation. We put it into a risk calculator, you know, take other things into context, your blood pressure, your weight, your family history, your heart disease history. We calculate your Q risk, and there are other things that would be relevant during that conversation. So I think it's a good opportunity to have a chat with someone about it rather than just doing it yourself. And I know people are trying to help themselves, so we're not saying don't, but yeah, let it just be a stepping stone for you to going to have that conversation. Thank you, Dr. Deji. Dr. Deji, could you please shed a little light on genetic factors? So Maya's saying that, you know, genetic factors causing Black people to be susceptible, as we've heard, not just to stroke, but we hear it about, oh, in hypertension, Black people are susceptible. In fibroids, we hear that, you know, we have a, you know, we get it more than others. And most of the time, we seem to be susceptible to a lot of things. Do you have the answer? Do you know why, as Blacks, we just seem to be susceptible to lots of things?
Not entirely. However, you know, genes are often an adaptive process, aren't they? And as we evolve through our societies, you know, the genes are, you know, they change along with us. There is a lot of work being done on those genetic disparities, and you can see that in my slides. That I did suggest that, you know, we need to engage more with research wherever possible to give us those answers that we're looking for, especially for the Black community. Otherwise, we will be left behind in this kind of battle to suppress strokes.
Yeah.
The other thing is that's interesting is that there may well be a generational difference as well, because first generation Blacks in this country may react completely differently to second and third generations because of the adaptation along the line. So it's an interesting thing to do. And a lot of studies are required. As to whether there are any specific genes, I do not know, but I do know that there's a lot of research in that field.
Thank you. Yeah, and we do need ongoing research as well. So we do need to come forward and volunteer for some of these researchers, because that's the only way we get to know about ourselves, if we are part of this. So thanks for that. Just a few comments which I'll read. We've talked about the cholesterol bit. Jay again is asking about whether aspirin would be recommended for a long haul flight to prevent a blood clot. So I'll just pass that to you and I'll come to that in a minute, but I just want to read a few comments. So someone is saying, interesting conversation on salt. The guidance of 6 grams is benchmarked with white people. Advice is not tailored to us, so we should be encouraged to have less, exactly, which is what we're all saying. And also there's the issue of culturally, you know, the labeling of our cultural foods as well. So yeah, that's a very interesting point there. Again, someone is saying, Mai saying, I would like to digress a bit and talk about the cultural and ethnic challenges, which are featured in a few slides. As most workplaces are putting equality, diversity, and inclusion training in workplaces, to what extent are the same practices being considered with the Black community? So maybe we could take those 2 themes, the aspirin for long haul flight to prevent DVT, and then talk a bit about sort of what can be done really in terms of inclusion and diversity and at workplaces for Black people, please. Your thoughts?
My thoughts, yes. I mean, the one about deep vein thrombosis is right up my street as a vascular surgeon. I get asked that all the time. And and what I tend to say is that, as you know, a lot of us fly a lot of people fly every single day. The risk of a deep vein thrombosis from a long-haul flight is generally quite low. However, if you're at a higher risk or you do certain things, then there is that chance that you need to protect yourself. So higher risk meaning like you've had a deep vein thrombosis in the past, you're pregnant, for example, or other things that will increase your what we call your venous pressure in your legs during that period of relative immobility, then you do need to do certain things. And the simplest thing you can do is make sure you're hydrated, walk around the cabin, etc. Those are the simplest things you do. As to whether aspirin per se prevents that, there's no evidence that it does. If you came to me as a surgeon and asked me, I probably would look at your risk profile. I wouldn't not dissuade you from aspirin to say, even though there's no evidence, if you have a slightly higher risk factor. Those that are clearly have had a risk factor, such as if you've had a DVT in the past, I would probably suggest more have an injectable form of an anticoagulant just before you go and on arrival or when you're coming back as well. That would be my practice. Some of that is not evidence-based, I admit, but it's the next best thing, because the whole issue about long-haul flights and flying and deep vein thrombosis is a thorny one at the moment.
Yeah, yes. And to add to that as well, hydration, keep moving, wearing your anti-embolic stockings. And as he said, speak to your clinicians and know what your risk is, because there are those injectable antiplatelets, which if you need them, then would be sort of issued for you as well. Should we touch briefly on that equality diversity bit as well? About sort of what can be done in the workplaces, because we know that as Black people, where these challenges do exist, don't they? From your point of view, is there anything that you might suggest or you've encountered in your career?
I think that we need to get past the conversation and I'll say the blanket conversations, that kind of say that, and I'm getting past the tick box, and I'm not trying to be political here, so when you look at some of the work done in the States, they look at kind of culturally aligned initiatives, things that actually talk to the people of relevance, So should we have champions within our organizations, public organizations, that actually this is what they do, and they can talk to both sides, talk to both stakeholders and policy makers and the community. But I do feel that it is a lot of the work has to be done by us, from us, in order for us to be empowered, and we get empowered by having a louder, more relevant voice, not a voice that just says anything, but says things based on facts.
Absolutely. And each and every one of us is our champion in our own right. Make that little difference that you can in your small corner. No matter how little you might think it is, it will make a difference. Thank you for that, Dr. Deji. So Kojo says, thank you, Dr. Olojugba, for a simplified and clear presentation. Anthony says, thank you for brilliant presentation. And lots of other comments along those lines as well. Bumi says, thank you for the helpful session. Maya, I think we've addressed your comment and your question. And Fiona is saying, are there certain, so I'm just going to bunch a few things because of time. So, and Pastor Chini says, thank you as well for the educative information. So Fiona is saying, are there certain drugs that are used to manage our stroke risks better, the Black person's stroke risk better? So are there certain drugs? That's one question. Loretta says, other races also have what they are susceptible to that we are not. Yeah, that's a lighter side. I like that. So it's not just all about a dark and gloomy for being Black. Yeah, other people have their risk factors. Thanks for that. That's a cheery one. And Roy is saying as well the same. Thanks for everything. So I think the last question is in relation to, are there certain drugs that are used to manage our risk better as Black people? And I just want to ask you a question. Being a vascular surgeon, I'm not going to let you go without asking you something not linked to stroke, but to do with varicose veins. I have a lot of patients who come and say, what can I do for my varicose veins? And there's very little we can offer them, apart from, you know, giving them the advice and all. And if they're not having complications, some people still want to have something done. So only if you've got 2 minutes to chip on something about that, but I'll leave that to you. But let's please address the question first about, are there certain drugs that are better for Black people?
Specifically for Black people, no. Unless, you know, you're talking about things like sickle cell, okay, where you need to manage those directly, and that will reduce, you know, the risk of strokes in those. But I think the more important thing is where the emphasis is, you know, and us and everyone understanding that the emphasis is slight, at least for this generation, is slightly different. The emphasis would have to be on hypertension, you know, and all the things that surround hypertension, because the effect seems to be more within the brain itself, the small vessels of the brain, and the chronic effects of that. So how do we control hypertension? How do we control diabetes? And Diana, as you'll know, that the drugs you give to control hypertension in a white person are perhaps different from the drugs you give to control diabetes and hypertension in a Black person. So that's where the divergence, I guess, starts. Even though we have almost, you know, the list of the list of risk factors is very similar, but the emphasis and the effects of those is different.
Yeah, thank you. And what should I do with my varicose veins patients?
Send them all to my private clinic. No, that was a joke.
Good. So tell us, do you do some private work, and where can we find you?
Yes, I do some private work. I was trying to wind up, but I work out of Warrington and Chester. But a plug on varicose veins. You know, when they did a quality of life study on varicose veins and the surgery on following varicose veins, it is one of those procedures, a bit like hip surgery, where you have the biggest benefit in terms of quality of life after treatment. Mm-hmm. The government would like to ignore varicose veins because they see it as a procedure of low clinical priority, but it affects people. You know, hardworking people go to work and they come back and they've got their legs are swollen, it's in pain, it's aching, and we're not even talking about complications just yet. So treatment is important beyond the appearance, beyond the cosmesis, and treatment is well established and should be available. The problem is making the case for having the treatment. NICE guidelines are very, very clear. They do say if you've got symptoms that your patient should be offered intervention, which is usually a day case procedure, either laser. We don't do open surgery these days, but there are a lot of kind of minimally invasive procedures that we do. But NICE guidance is very clear. The problem is that the CCGs now renamed something else. Have had to hold their purses and close their purses, and I think that's where the holdup is. But yeah, if your patient gets through, it's just that certain places don't do them on the NHS, and that's a shame.
That's the trouble, isn't it? Yeah. So on that note, I think I'm going to kind of twist your hand into another date. I'm afraid we will probably have to bring you back to talk specifically about varicose veins, because I can see the questions flowing already. Someone is saying, you know, people can wear compressions, yes, and all of that, but what do people do if they have bothersome symptoms impacting them? So maybe we can talk about that. And also someone has, so Abby, I hope that would settle you, and there will be a session, we'll try and arrange that. And Hazel has also said, what a brilliant session. I'd love to know more on DVT and what to look out for. So the team will take note of that, and we will try and organize a session on that. And also Hazel says, I'm assuming there is a link of stroke and high rates of dementia. So we can address all of those. So please keep tuned into these health hour sessions, and week in, week out, we will try to bring you topics that would be relevant. And thank you for all the feedback. Thank you for all the comments. Thank you for taking your time to listen. Thank you so much, Dr. Olojugba. It's been a lovely session, very useful, very educational. We've been empowered, and I know that we've all been championed to go and be champions in our own small way. God bless you. It's been my pleasure to host you all. My name is Dr. Darren Asante, and our guest for today has been Dr. Deji Olojugba. Thank you for the team that has been supporting us behind the scenes. I will hand over to Ngozi to do the closing for us. Thank you, Dr. Deji.
Thank you.
Good afternoon, everyone. Yeah, good afternoon, and nice to see you all. And thank you once again, Dr. Olojugba, and thank you, Dr. Diana, for the fantastic hosting as always. And I want to say a big thank you to all the Catholic partners for all your work and getting people to attend these events. Thanks a lot to Black Health Initiative, Croydon BME Forum, Enfield Caribbean Association, and then Royal Assembly RCCG in Sheffield, and Rafa International in Birmingham. So I want to say a big thank you to all of you, and of course to CAHN for your help. There are different things happening around, and the different partners will be sharing in their different regions. So I'll just share with you some of the events coming up in CAHN. Very exciting times. So yeah, if I can get the slides up, please. Thank you. So yeah, so we have from next week, we've got one of our partners presenting a healthy living lifestyles event in Birmingham next week. So please, if you're around the area or if you're going to be there, so please join next week, the Healthy Living and Lifestyles event happening next week. For details, please contact Angela at Rafa. Thank you. Next slide, please. The next week's health hour will be on hypertension and the causes and management. And we've got Dr. Mohammed Kamara will be speaking next week. So please join, and it links back to what Dr. Deji talked about today in terms of BP monitors. So if you have questions around that, please join next week and ask your questions. And then our Healthy Heart session will be happening on Tuesday. And this is an interesting topic. So please tune in next week. It's about autism and nutrition. And our guest speaker will be Dr. Alice Owang, and is a registered dietitian, and Dr. Hiba will be our usual host. So please tune in next week to find out more. And yeah, here comes a really exciting part. We have our Black History Month launch event, which is coming up on the 28th of September, not too far, and that will be taking place at Manchester Cathedral. So that will lead up to our main gala event, which is happening in October. So our gala event is an opportunity for us to, showcase what we do, fundraise, and help us with the things we do at CAHN. And it's going to be a glamorous event. There's a link for you to join. And we also have a nomination awards before then. So you can nominate people in the society, in the community, who you think they've done great things. Please feel free to do that. And then just before you go, please hang on. We're going to share a very interesting video about our gala. Thank you.
CAHN is holding its annual gala on Saturday, 22nd of October, celebrating its 5th year anniversary, annual awards, and its official Black History Month fundraising. The compere for the evening will be Sky News presenter Gillian Joseph. This year's gala will be held at the Hilton Hotel, Manchester Deansgate from 5:30 p.m. until late. Tickets are £75 per person, and there's a special discount available for over 65. For more information, visit cahn.org.uk/gala or email bhm@cahn.org.uk.
Thank you very much for that. And we look forward to seeing you at the gala, and we look forward to seeing you next week at our Health Hour session. Thank you for joining. Have a good weekend.
Welcome to our Caribbean and African Targeted Health Improvement Program, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our Health Hour sessions. Spread the word in our community. CAHN is funded by the National Lottery Community Fund.